I think you've just all gotten a great peek behind the curtain about how the sausage gets made, and it's really fantastic because, as you can see, we've literally stacked all of these different processes in parallel to ensure that we can get across the finish line in as quick as possible. Normally, these would all be sequential and spread out over several years, and here we are, probably a lot faster to where we would have been, but we still have a ways to go. So next slide. So as Dr. Aronson mentioned, we are really close to that truly same-day test and treat approach, and we really just need that hepatitis B surface antigen. There is some good news, which next slide you will see. The FDA has put out its proposal for down classifying HPV diagnostics on the Federal Register. This is one of the penultimate steps needed to ultimately then down classify HPV diagnostics, which has happened for HCV several years ago, which unlocked what you see today. And we hope that we'll follow a similar process. The comment period actually is still open and ends in November around Thanksgiving time. So if you want to give a plug for how important this is, feel free to follow the link below. Next slide. And as mentioned before, like we have this ongoing point of care hepatitis B surface antigen solicitation in anticipation that we're going to need this really soon. And so this process allows for one of the existing tests, or maybe a test we don't even know about, to come to market in a rapid fashion. That solicitation is open as well, and the link below is how you follow it to submit your application. Next slide. But, I just wanted to kind of level set and zoom out a little bit. There's still multiple barriers to hepatitis C treatment. Give it one click. So with all of the work that you saw today, we are taking out this two-step diagnostic testing barrier, but there's still all these barriers that exist. Next slide. And Dr. Collins had mentioned, what we really need to eliminate hepatitis C is what's contained in the National Hepatitis C Elimination Program, which would drastically increase funding for improving diagnoses, improving treatment, and then ensuring that there's a public health campaign for implementation to ensure that all of this is happening in the places where we need them the most, in the high impact and healthcare settings where the people with hepatitis C seek care. Next slide. And we're really hopeful an early analysis by the Congressional Budget Office suggested that for the Medicaid population, there's substantial cost savings. And should that be similar across the entire plan, that would be almost a sense of a green light. And so we're crossing our fingers for that. Next slide. So one thing that we wanted to pull in some voices is, although this is a new technology, there's already some folks jumping in and starting to use it, or maybe have been using it. So I wanted to invite to the floor Jennifer Havens first, out of University of Kentucky, to share very briefly about her experience using Expert HCV. Go ahead, Jennifer.
Thank you so much. I've been conducting a clinical trial, the Kentucky Viral Hepatitis Treatment Project, implemented in 2019, that's funded by the NIH. I've been working in an area in Appalachian, Kentucky, leading a longitudinal cohort study where we found high rates of HCV seropositivity amongst people who were injecting opioids. And so really when the folks from NIH came together to talk about what next steps were, really getting these new, at the time, new DAAs into the hands of people who were using drugs was a priority. So when we were looking at models of care, there weren't a lot in the United States. So we were really looking to other countries, and Australia has been mentioned. And they were already employing point of care RNA testing and same day test and treat. So I made that the model of care for the Key Treat study in the hopes that when we got to the end, hopefully of the study, that we would have a point of care RNA test available and we would have results from that. So we've been using the Cepheid device. We were able to receive a research exemption from the company to utilize the assay, and we were using the quantitative test, but we've also used the qualitative test as well since we are part of the clinical trial that was mentioned by Dr. Lai. And we were not only using it for diagnosis and that same day test and treat model, but we were also using it to determine cure. And throughout the study, when folks came in after they had initiated treatment to look at adherence. But a really interesting finding from our standpoint was that it was a clinical trial. We did have loss to follow-up, and even though we've been doing cohort studies for years and have what we think are really fantastic follow-up protocols, we did have almost a quarter of folks who were lost to follow-up. But since we had been conducting RNA testing, we knew that almost 40% of the folks that we had lost to follow-up were actually, even though they hadn't completed treatment, were actually already undetected. So from a public health standpoint, I think that was really important. And having the point of care test allowed us to track that over time. So I think it's been a game changer, especially in very rural areas. The biggest take-home message, I think, for Key Treat for us was, given the lack of transportation in this area, there's no public transportation, no taxis, no rideshare services, no Uber, no Lyft. So really minimizing the points of contact was really important, I think, for this study. And the point of care test absolutely allowed us to do this. We also received a drug donation from Gilead so that we could put drug in hand to folks who tested RNA positive. And please do follow up with me if you have any questions about how we employed the point of care RNA test. I'm happy to answer those.
Thanks so much, Jennifer, for that brief note from the field. I want to turn it over to my colleague, Colleen Flanagan, who's from the New York State Department of Health.
Thanks, Nate. Hi, everybody. So we are excited for the FDA approval of the Cepheid device. We do have some state dollars to make an investment in the device. We are how we came to the decision as to where we are going to be employing the device is through our very large hepatitis C community-based rapid antibody testing program, where that program has been in existence for over 10 years now and has evolved over time in terms of how an RNA test was provided to an individual, from referral offsite to a small contract with Quest to do phlebotomy blood draws, which did not last very long because, as Nate pointed out, the sites that have the highest prevalence of Hep C do not have staff that can do venipuncture. And I think, as one of the other presenters pointed out, people who use drugs do not always have good veins. So the New York State Public Health Lab validated DBS, dried blood spot, for RNA testing, which was great. Finger stick. Almost all of our sites are using DBS testing right now. But when we look at our data, we still see a fair number of individuals not coming back for that test result. And so that's really where we see a role for point of care testing, to be able to give that diagnosis at the point of care. And so our plan is to provide funding to our drug user health hubs, which are an extension to several of our syringe service programs in New York State. They offer wraparound services, including medication for opioid use disorder. And I'm happy to say some of them are actually offering hepatitis C treatment, some through some funding that we provide for co-location of hepatitis C in these drug user health hubs. And so we're excited to be able to see how this test works in these settings. We are concerned about workflow, and we know that that's something that these programs are going to need some technical assistance on. This is different. This is not a 20-minute test. And so what does that workflow look like? And then we also have to think about access to treatment. While some of these sites are providing treatment on site, the medication itself is not being provided on site. And so what does that mean? So appear to navigate that individual to the community pharmacy, establishing a relationship with the community pharmacy to make sure that that medication is there. Most do not stock it. And so those are some of the things that we anticipate as challenges. And I think, just thinking about what Jennifer said about the quarter of individuals who still did not return or were lost to follow-up, social determinants of health are extremely important, and addressing those social determinants of health as well. We are going to use the device in some of our clinical sites that have integrated hepatitis C treatment into primary care. I don't think most of these sites will be using the device in the clinic themselves, but more out in the community in high impact settings.
Thanks, Colleen, for that brief note from the field. And for a final brief note from the field, I wanted to turn it over to Tyler Bartholomew out of University of Miami.
Yeah, thank you, Nate. I'm going to be short because I know that we're running overtime on this, and there's not much more I can add to this webinar. It was fantastic to hear this rapid translation of this technology and all the amazing people doing the work behind the scenes to make this happen. So I'll just highlight kind of two things that haven't already been discussed by Jennifer and Colleen. As we move forward and really focus on certain services programs as these optimal venues to reaching people who inject drugs, we need to make sure we have equitable implementation of this technology. We're going to have a lot of programs in different places in the country that are going to have resources and their health department stepping in and fronting the bill to do that. But there are a lot of programs that don't have access to funding, support, implementation, help with getting this type of testing technology stood up. And so I would say focusing on equitable implementation needs to be key if we really want to make viral hepatitis elimination a priority and a thing. The second piece is integrating telehealth models into this type of care flow is really, really profound. My work and others at the University of Miami with the Idea Exchange program have been focusing on telehealth or peer-driven telehealth models, what we call teleharm reduction, to bring care to the people where they are. That might be at the needle exchange program. That might be in the field under a bridge. That might be on a mobile unit. There's different locations, different places as to which we can bring care. And what we see is that this type of telehealth approach of medication management, peer navigation, motivational interviewing, embedded into our harm reduction services, right? So not only are we able to drop off medication for folks, but we're also bringing them syringes, injection equipment, naloxone, fentanyl test strips, the whole comprehensive package of harm reduction supplies along with treatment. And what we see in our HIV treatment trials, thinking about that retention component is, even at 12-month follow-up in our intervention studies, we have 95% retention. And I think it's really, really important that we think about treatment models that are non-stigmatizing, low barrier as we move forward, and leveraging the SSP as an ideal and optimal venue to do implementation. But we need to make sure that those programs are supported, they're sustained, and that they can actually do these interventions moving forward. We have great progress, but if we don't, support the bed of foundation of how we're going to reach folks, we run the risk of not actually making a difference. So just really excited about the opportunity, but we have a long road ahead to make this a reality.
Thank you, Tyler.